The Frank-Starling Law is arguably one of the most important principles in all of cardiovascular medicine. Otto Frank and Ernest Starling discovered this separately, but jointly arrived at the conclusion that as you distend the ventricle up to a certain point, you're going to stretch out the sarcomeres, calcium sensitivity is going to increase for troponin C, and during systole, when you actually snap back, it's going to be much more aggressive shortening of those cardiac myocytes, which is going to translate to increased contractility, increased cardiac output. Now, when we look at these actual curves, the y-axis is normally along the lines of cardiac output or stroke volume, whereas the x-axis is something along the lines of preload or LVEDP, left ventricular end diastolic pressure, which is a surrogate for preload as well. Now remember, this is an intrinsic property of the myocardium. So even denervated hearts will exhibit this. For example, the transplants that I'm involved with, I have to consider where patients are on their Starling curve. If I give too much volume, I may be shifting them too far along their curve where they start to fall off because the heart gets congested, and especially the right ventricle will have difficulty mobilizing that fluid forward. The reality is we actually don't know where patients are on their Frank-Starling curve. Even the new invasive monitors try to pinpoint where patients may be on a little diagram, but we really don't know. And we have to do things like volume challenges in the form of passive leg raise or a fluid bolus, diuresing patients, trying to move them backwards along their curve. But this is going to manipulate patients along an existing curve. As soon as we have a change in contractility or afterload, we're going to shift a patient's Starling curve. If we have a drop in afterload or an increased contractility, something we sometimes see in sepsis, where we have a hyperdynamic left ventricle because the patient's in vasodilatory shock, their curve may get shifted up and to the left, whereas someone who's got really bad ischemia and may be having cardiogenic shock will be shifted down and to the right. Based on where you think their curve might be, gives you a rough idea of how they may or may not respond to fluid or diuresis. Now, the other area where this is super relevant for me, both in the operating room and in the ICU settings, is resting the heart. When we've got patients with mechanical circulatory support, whether it's ECMO or LVADs or anything like that, it makes sense. If you empty out the heart, you decrease the preload to the heart, that the ventricle no longer is going to stretch as readily and it won't contract. And this will actually decrease myocardial oxygen consumption by decreasing wall stress, which is an important determinant in O2 consumption, along with heart rate and contractility states and things like that. This is also why we do things like venting the heart on cardiopulmonary bypass. We want to keep it empty. We want to prevent stretching of the ventricle to decrease contractility, decrease the overall wall stress for the purposes of resting the heart, allowing it to recover. And this explains why some patients with LVADs, for example, may or may not be truly pulseless. If they have their power cranked way up and they have good flow and they're emptying out their left ventricle, now the LV is on vacation. It doesn't have a reason to really contract. So your aortic valve's not going to open, your left ventricle is not going to really generate enough pressure for it to open the aortic valve, and you're going to be in more of a continuous flow physiology. If you start to slow down that pump, whether it's ECMO and LVAD, anything like that, and start to actually fill the ventricle, now it's got more of a reason to dilate, stretch out, and then snap back, generate enough pressure to open that aortic valve. And this is something we're trying to balance, for example, with new LVADs, where we want the aortic valve opening, but we also want to make sure there's plenty of flow through the LVAD, that there's not any significant change in the interventricular septal position, things of this nature. Another important consideration, I think, we do a really good job of talking about this in med school when we talk about the kidneys, for example, pre-renal, intrarenal, post-renal. We need to do that with the heart, but in particular talking about the left and right side separately. When we talk about preload to the heart, we're just assuming venous return that's coming back from the SVC and IVC to the right atria. Instead, we really do need to be thinking about the left side of the heart separately from the right side. Why? Because if you've got a patient with an empty left side, could it be that they're systemically hypovolemic? Sure. But could it also be that the right ventricle is actually not sending fluid and blood and everything to the left side? Absolutely. And this is a big consideration that we have after mechanical circulatory support, but in patients with recovering hearts, sometimes one side of the heart recovers better than the other. Sometimes patients have infarcts just to one side of the heart. They've got really, really bad right ventricular dysfunction, but the left side looks okay. Maybe they have really bad pulmonary vascular resistance and now the right side's failing, but the left side's empty because the right side's not sending anything to it. So when we're considering where patients are on their Starling curve, we have to also consider the effects of changes in afterload and contractility, as I mentioned before we just start to give fluids or diurese them, which can be really, really detrimental if you don't really understand the physiology at play. So again, just to recap, the Starling curve basically is talking about how additional preload to the right ventricle and the left ventricle will distend the ventricle and allow it to snap back more aggressively up to a certain point. If you overcongest the ventricle, you won't be able to get any additional increase in stroke volume. In fact, it'll actually harm your stroke volume because of that overcongestion. If you have a change in afterload and a change in contractility, that'll actually shift your Starling curve differently. If you're diuresing or giving volume, you'll be shifted along the Starling curve. Thank you all so much for watching. Hopefully this video answers a lot of your questions regarding the Starling curve. Drop me comments below with questions and I'll catch you all in the next one. Take care.